Welcome and good morning. 在中国的各位同行，晚上好。I'm Mark Elliott, Vice Provost for International Affairs at Harvard University, and it's my great pleasure to get things started today at this symposium on global perspectives on COVID-19. I hope everybody is keeping well. 2020 has been a momentous year, I think we can say. It will go down in history. It's been a year full of challenges for all of us everywhere in the world. If you were a historian, and as it happens, I am a historian, you could say that it's been a privilege, actually, to be able to live through these tumultuous times and witness firsthand what a historic turning point probably feels like, and what it might have felt like to people before us living through similar such transformations in world history in the past. And indeed, it is a privilege. It's a very great privilege because to be able to live through these times, I say, because as we of course know, not everybody has been fortunate enough to live through them. For all the uproar in the world today, with the death toll from the pandemic now at over 1 million people, there can be no question that the greatest challenge of the many that 2020 has thrown at us is undoubtedly the novel coronavirus and COVID-19. This monumental public health crisis has required all of us to do our part as responsible individuals to at least slow the spread of infection. It has inspired those of us in the medical and health professions, many of you have joined us this morning, inspired you to take risks in addressing the needs of those who have fallen ill. And this crisis has called upon institutions like Harvard to do much more than that even. Given the knowledge, the talent, the experience, and the resources at Harvard Medical School, as well as at the Harvard Chan School of Public Health and at other Harvard schools, at our affiliated research institutes and our affiliated hospitals. And given the dimensions of the crisis, it has perhaps never been more important for us than it is now to shoulder the responsibility to respond quickly and effectively to the threat posed to human lives and to the health of our communities, local, regional, national, and global. The formation of MassCPR, an unprecedented collaboration uniting the greater Boston biomedical research and clinical community, is the result of our commitment to live up to that responsibility and that moral imperative. With the generous and inspired support of the Evergrande Group, Harvard not only has created a collaborative consortium of unparalleled research capacity here in Boston, but we have been able to team up with the Guangzhou Institute of Respiratory Health to mount a comprehensive and historic partnership that will bring benefits to all, to Americans, to Chinese, and to people all over the world who are looking for answers and who are hoping desperately for an end to this pandemic. As the research already accomplished to date shows, and we'll hear more about that research later today, MassCPR is giving us hope. I want to thank Dean George Daley for his tireless and visionary leadership of MassCPR, along with the entire leadership team at HMS, in particular that of David Golan, Arlene Sharp, and Bruce Walker. I also want to thank Dr. Zhong Nanshan for his leadership at GIRH. 我还想要谢谢钟南山院长，他作为广州呼吸健康研究院的领导，做出的贡献特别的多，也特别的重要。尤其现在，当中美关系搞到最低点的时刻，他坚持不移，一直支持我们这场合作。我代表我们哈佛全体师生表示衷心的感谢。Let me also give special thanks to our friends at Evergrande Group, without whose support this collaboration would never have come about. Having joined a number of previous seminars at MassCPR, which are always early in the morning and therefore avoid conflicts with other meetings, I know we are in for a very informative symposium today. It's a special one because this is Worldwide Week at Harvard. I want to thank everybody involved in preparing today's session for their time, especially our friends around the world. And let me also thank everybody who is working so hard every day in Boston, in Guangzhou, wherever, whatever hospital, whatever institute you're at, looking for solutions to the problems we face. We are all deeply, deeply grateful.
Thank you for that introduction, Mark, and for inviting Harvard Medical School and the Massachusetts Consortium on Pathogen Readiness to present this symposium today as part of Worldwide Week at Harvard. Good morning, everyone, or good afternoon, or good evening, wherever you are, given the global nature of this program. Last week, our world reached a grim milestone: 1 million deaths from COVID-19. For a pathogen barely 10 months old, SARS-CoV-2 has extracted an unspeakable human toll. The pandemic has also devastated economies and forced us to radically transform the way we socialize, work, and learn. Conquering this contagion will depend on unraveling the biology of the virus, understanding the pathophysiology of the disease, and developing treatments and vaccines to halt its spread. Vanquishing COVID-19 will depend critically on how we learn from each other and how we collaborate as a global biomedical community united against this common threat. And this is precisely why we're here today, to share the regional insights from the early days of the COVID-19 pandemic that hold lessons for all of us collectively. Now, while it's a truism in public health that all epidemics are local and demand an intense local response, when contagion jumps local boundaries, containment strategies must quickly become more extensive and coordinated. The insights that today's presenters will share from the early days of the epidemic in China, Italy, and Africa illustrate how we can learn from one another's experience so that we can develop refined strategies to combat any future resurgence of infection. One of the earliest and most profound lessons comes from our colleagues in China. The Chinese experience is a case study in how quick recognition of a novel pathogen and a rapid, coordinated lockdown on an unprecedented scale resulted in control of the virus. As we will hear, China remains vigilant, aggressively responding to local outbreaks and remaining very wary of reimportation of cases. Then came another valuable lesson. Healthcare systems, first in China and later in Italy and around the world, reorganized nimbly to handle the spike in seriously ill patients, building makeshift pop-up hospitals with unprecedented speed, and diverting clinical resources and human power to absorb and manage the surges. Our colleagues in China and Italy shared these invaluable early lessons with us. And I want to pause here and acknowledge the incalculable value of this advance warning and the generous flow of clinical and scientific knowledge from our colleagues in China and Northern Italy. They provided us with ample warning about the hurricane headed our way, enabling us here in New England to prepare for the surge and avert catastrophic overload of our hospital systems. Unfortunately, the US failed to mount a coordinated national effort, and some parts of our country did not heed the early warnings from abroad, choosing instead to ignore the very public health measures that had worked to ultimately bring the explosive virus under control in these early epicenters of the pandemic. To this day, the United States continues to struggle to contain the virus, and the death toll continues to mount. Looking ahead to the end game of this pandemic, herd immunity achieved through vaccination remains our best chance for stemming the tide and returning to some semblance of normalcy. And I know that today's speakers will have some tantalizing information on that front to share. We will first hear from Regan Murray, who will discuss lessons learned from epidemics past. Next, we will hear from the legendary physician scientist Nanshan Zhong from the Guangzhou Medical University, who discovered the first SARS virus and has led the Chinese response to both SARS and SARS-CoV-2. Dr. Zhong will detail the early response and evolving dynamics of the infections in China. Next, Salim Abdool Karim, Director of CAPRISA and a member of the African Task Force on Coronavirus, will discuss responses and insights from South Africa. Fabio Ciceri from the San Raffaele Hospital in Milan will share his insights from the early days of the pandemic in Northern Italy and its evolving nature in Europe today. And then finally, Paul Farmer will synthesize the lessons that we can and should all learn from each other and the challenges that lie ahead. Then we will open it up for questions, and please post them on the Q&A function on Zoom. Before I turn it over to our first presenter, just a few words about the Massachusetts Consortium on Pathogen Readiness, or MassCPR, which epitomizes this spirit of scientific collaboration across institutions and across boundaries. The mission of MassCPR is to address the immediate challenges of the COVID-19 pandemic, as well as the long-term imperative to ready ourselves for future outbreaks. Initially launched by Harvard Medical School in collaboration with the Guangzhou Institute in China, we are now a consortium of over 500 scientists from 17 regional institutions. It was initially enabled by the agreement between Harvard University and the China Evergrande Group, which funded Harvard and the Guangzhou Institute of Respiratory Health in China to advance research on the scale and scope needed to meet this extraordinary challenge. And now on with our program. I'll turn it over to Megan Murray.
So thank you very much for having me. I'm going to reach back into the past, and I really appreciate the introduction because we can frame this epidemic in historical terms. The first decade of the 20th century saw the completion of the Southern Manchurian Railway that provided the link between southern Chinese cities and the resource-rich region of Manchuria. The history of the railway itself is complex and fascinating, reflecting the strategic role of this area in the ongoing conflicts between China, Russia, and Japan. And by 1910, the part of the railway near the city of Harbin was co-administered by representatives of all three countries. The railway enabled goods to be transported out of Manchuria, but it also set the stage for one of the worst epidemics of the 20th century. Third-class rail tickets were cheap and led to a major migration of laborers from southern China to the north. In 1910, many of these migrants were moving to Harbin to hunt tarbagon. So this is a kind of marmot. It's a tarbagon, and the migrants had moved from the south of China to the north of China in order to hunt marmots, largely because German chemists had found a way to treat marmot fur to make it soft and appealing to European consumers. And marmot fur became a cheap alternative to sable. Tarbagon are a major reservoir for the causative bacteria of plague, Yersinia pestis. They're abundant in Manchuria, and lore has it that the local Buryat hunters are skilled at differentiating infected from healthy tarbagon and protecting themselves from infection during hunting and skinning the animals. And it was the inexperience of the migrant hunters that led to the first infections. Plague is usually spread by fleas, and human infection is marked by the characteristic nodules or buboes that give rise to the term bubonic plague. But direct inhalation of the bacteria can result in a rapidly progressive pneumonia with a mortality rate of 100%. The winter of 1910-1911 was one of the coldest on record, and migrant workers often kept warm at night by huddling together in poorly ventilated areas with 20 to 30 people per room. Pneumonic plague was first reported sporadically in the fall of 1910. By January, as migrant workers returned to their southern homes to celebrate Lunar New Year, it had spread along the railway lines, eventually leading to the deaths, advance the slide please, of between 50 and 80,000 people. To put that in perspective, the death count of the Great Plague of London in 1665 was estimated at 70,000, and the 2014 West Africa Ebola epidemic killed 11,500 people. Notably, almost all the dead were poor laborers and the healthcare workers who attended them. Fast forward to 1998. Advance, please. When a mysterious illness began killing farmers and abattoir or slaughterhouse workers in Malaysia. This turned out to be Nipah virus, then a newly discovered paramyxovirus that causes an acute encephalitis with a high mortality rate. At first, it was mistaken for Japanese encephalitis. The epidemiologic investigation implicated pigs as the main carriers of the disease and large commercial pig farms as one of the main venues for exposures. But how did the pigs get infected, and why only then? Can you advance 2 slides, please? 2 slides. Thank you. In 1997, Indonesia experienced one of the worst forest fires in history, at least up until then. Estimates range from 1.85 to 5 million acres burned. To put that in perspective, it's estimated that 4 million have burned in California so far this year, and about 2.5 million in the Amazon in 2019. The causes were controversial. It was an El Nino year. The Indonesian government originally blamed slash and burn practices of local farmers. But eventually, the Indonesian government censored a group of timber plantation companies for violating environmental protection laws. In any case, one thing the fires did was destroy enormous tracts of virgin forest that had been home to various Pteropus species. These are fruit bats that are now believed to have made their way to an alternative ecosystem in Malaysian pig farms, which often also contain mango groves. If you go back 1 slide, please. Bats eat mangoes, which fall from the ground, infected with Nipah virus. These are consumed by pigs, which go on to infect humans. The 1999 Nipah outbreak in Malaysia was limited to only 283 deaths, but it had a devastating effect on the agricultural economy, and several Nipah outbreaks have been reported since in Bangladesh and India. Next slide, please. 2 slides. Yeah, thank you. As we now know, bats also may have played a role in the emergence of Ebola in West Africa. The first known patient was a toddler who died of a mysterious disease in late December 2013. The child lived in the Ghanaian town of Meliandu, a village of only 30 households. Soon after, his sister, his mother, grandmother were infected as well. Some of the family members were treated in nearby Guangzhou, where they presumably infected some of their caregivers and people who attended their funerals. By February 1st, the infection had arrived in Conakry, carried to the city by one of the infected relatives who died soon after. Of course, one of the reasons that these infected people traveled was to seek health care, which they did not have access to locally. Meliandu is part of an area that had only recently been considered a biodiversity hotspot, but in which native forests had been systematically destroyed through mining and timber operations. Investigating epidemiologists identified this hollow tree that you see on the right here as a potential site of the first infection. The toddler who died and other local kids played in this tree stump, which was only about 50 meters from their home. The tree was later identified as a sheltering place for a species of bat, locally called lolibello, which means mice that can fly. Researchers identified DNA from the tree stump, which matched the bat Mops condylarus, an insect-eating species that is widespread through Central and West Africa. Of course, we now know what happened next, and I know that Paul Farmer will be speaking about his own work on Ebola a bit later this morning. The most recent Ebola epidemics have occurred in the Democratic Republic of the Congo, which has reported 11 outbreaks in total. The 10th lasted from August of 2018 until May 2020, and the most recent began in June of this year in the remote province of Equateur. There appears to be no connection between the 10th and the 11th epidemic, and it's likely that each represents a new leap from a zoonotic source to humans. Prior to these outbreaks, next slide, please. Researchers estimated that 20 African countries, including 22 million people, were at risk for such transfer events. Obviously, we don't know what's going to happen next, but suffice to say that once again, a devastating epidemic was preceded by major ecological disruption that may have led to the emergence of a zoonotic virus into a human population. And once again, it was the poor and healthcare workers who are most affected. Next slide, please. In some ways, the answer to the question of why the poor are most affected by epidemic disease seems obvious. But in other ways, not so much, as we've learned painfully from recent events. Another epidemic disease that we can learn from is one that is not a zoonosis, but nonetheless spreads widely in vulnerable populations. Of course, I'm talking about tuberculosis. My team looked at data from India on the frequency of self-reported TB across economic strata and found a remarkable differential by wealth quintile. Of course, the conditions of poverty, crowding, poor ventilation, facilitate TB transmission. But like COVID-19, TB does not cause symptomatic disease in most of the people it infects. When we looked at the distribution of major risk factors for TB progression in data from the Indian Demographic and Health Surveys, we found, as expected, that most of these were far more common in the lowest economic strata: tobacco, alcohol, low BMI, exposure to indoor air pollution through the use of biomass fuels for cooking. Only HIV and diabetes stood out as exceptions to this pattern, but we know that in many other settings, these comorbidities also track with poverty. Next slide, please. So what can we learn from these epidemics? First, many emerging diseases are zoonoses that make the species jump at the interface between human habitation and what was wilderness. So far, we don't know the circumstances of the SARS-CoV-2 species jump to humans in China, but we know that as more and more of the natural environment is destroyed by fire, mining, logging, urbanization, we can expect more such events. Second, we know that human mobility enables disease spread to new areas, and that as global mobility becomes more commonplace, we can expect to see wider dispersion of disease. Much of the current mobility we see in the world stems from the displacement of people for socioeconomic and political reasons. And these kinds of mass movements are also likely to increase over time. Third, epidemic disease differentially affects the poor and the most vulnerable members of society, and the people who provide them with healthcare. This reflects their likelihood of being exposed to the disease in the first place, their increased risk of severe disease if they are exposed, and their lack of access to high-quality healthcare when they do develop disease. And lastly, as each of these points makes clear, epidemics expose the fault lines of our society, and we cannot address them without seeing and trying to mend these fissures. Thank you.
Thank you very much, Megan. Let's move very quickly to Dr. Zhong.
Yes, thank you very much, George. So, good morning, ladies and gentlemen. So I would like to make some points about how we control COVID-19 in China. So I think that's the first discovery cluster infection of COVID-19 in China by Dr. Zhong, who's the chief director of the Hubei Integrated Traditional Chinese and Western Medicine Hospital. She reported cluster pneumonia in a 3-member family at the day December 27, and then she make a report to the local health authority and the central health authorities. Yes, and the so that yes, I'm sorry. Yeah, so Dr. Gao, the director of CDC in Beijing, had make a separation of the virus and make a full length gene sequential analysis in the day, the 3rd of January. And then I think make a report to the WHO and also the global initiative on sharing all influenza data that in the day of 10th of 12th. And then that at that time, I think the how serious of the contagious disease are, well, it's not that very much clear. So until the day of the 20th of January, so after thorough investigation by 6-member national high-class expert committee. They announced definite human-to-human transmission and, for this event, and also confirmed of medical staff had been infected. So generally, in dealing this kind of acute infectious disease, and then people just try to take some action to contain the number of patients under the capacity of national health system, and then try to do that. How did the Chinese government do that? So the next one, I think having the very painful experience during the outbreak of SARS 17 years ago, that's 2003. So two ways to go. One is suppression and other mitigation. So suppression, of course, that will cause a great impact on the economy. However, the mitigation, the moderate action, whether they will control the disease or because there's a high reproductive index, may not be controlled. Therefore, which point? The very important point is in the top people in the government, life supremacy, that will be the dominant idea. So they decide to go that way, suppression. What kind of suppression here? You can see lockdown Wuhan, that's 2 days after our announcement, and make it more transparent, real-time announcement of the number of diagnosed patients. More important action is the so-called inter-agency mechanism. So early protection, the so-called distancing, wearing masks, hand hygiene, early diagnosis, early isolation, early treatment, down to the community level. It's a little bit compulsory, but people have to do that, and every people. So RT-PCR test and contact, close contact, including those. So another thing is how we deal with the epicenter in Wuhan. So to isolate patients from their families and close contacts, the first makeshift hospitals have been set up after 12 days after announcement of open that, and totally 16 makeshift hospitals. So with 13,000 beds set up within 19 days. So by this action, so in China, in Wuhan, the whole total daily new diagnosed patient, so increased in the first 2 weeks, and then reaching the peak, and then declining after 2 weeks, all together 1 month. That will be going back to the original level. So after that, it's quite stable at the beginning of inside China. However, there are some import cases coming. So I would give you the whole things like this. So, like this. So the cumulative number of patients remain relatively stable since the beginning of March. So 80,000. So after 7 months, so 3 days before is 91,000. So only 10,000 after 7 months. So that's some sporadic events in Heilongjiang, Jilin, Xinjiang province, and Beijing, and including close to 3,000 import cases. So by this way, we catch the time during the stable period of half year. So we are able to reopen the economy. So that's a very important view, mainly due to the so-called interagency, the so-called for earlier action. So that's the first thing I would like to mention. The second point I would like to mention whether there are some reinfection people. Yes, I think I feel. So that I just raised 3 cases. One case in Hong Kong, China, a man with 33-year-old. The first infection is March, and the second infection, so August, 5 months apart. So when we make an analysis of the strain, we have found the clades and lineage is quite different from each other. That's the first one. And the second one in Nevada in the US, a young man with the first infection in April and the second June, that's 2 months apart. However, in the COVID-19 virus analysis showing the larger degree of genetic discordance between 2 episodes, it's not just one infection. That's the second one. And a case 3 in Belgium, a female with 51 years, so the old, and the first infection March, and the second June, that's 3 months apart. And also the virus analysis showing, so 2 different lineage, B11 and A. That's the 3 cases. Actually, it's not that many. So what we have learned from this so-called reinfection. First, reinfection is possible, but very uncommon. Why is that? So in those subgroup of patients, antibody may create, but decline very rapidly. So that's one reason. Another reason maybe no or very weak antibody response in the first episode, which were unable to block the second infection. That's the reinfection, the mind. Oh, the last I would mention about the strategy of prevention. The best thing is herd immunity, just as George mentioned. So I think natural infection is not the way. So we will have 3 million lose of the life. That's not the way. And of course, that's mainly depend on massive vaccination. Need time, of course, the 1 to 2 years from now on. So we need a global collaboration. What's the situation in China at the moment? So we're all together, we have 11 branches, kind of vaccine on the clinical trial, phase 1 or phase 1 to 2 and phase 3. And here you can see inactivated vaccines are recombinant and the virus vector vaccine. There's 2 and actually 3 Wuhan, Beijing branch of biological products and Sinovac, and that's. And then the CanSino biologics. So 3 of these. So it's impossible to carry on this phase 3 study. We have no patient in China at all. So we have to have some collaboration with other countries like United Arab Emirates and Bahrain and Jordan, Brazil, Indonesia, Turkey, Bangladesh, and Russia and Pakistan. That's the phase 3 will be available at the end of this year. And phase 2, 1 to 2, that's 7. And one of them, DNA vaccine, is that's from Suzhou, have a close collaboration of Inovio Pharmaceuticals in the US. And phase 1, there are 3. And one of them close mRNA vaccines close collaborate with the Germany company. That's what I think. So the challenge of the COVID-19 control, I suppose a strong action by the central government. That's the blocking the transmission role in the community level, still the most effective way for disease control up to now, I think. The second will be vaccine development, of course, the key for establishing herd immunity. So there's an urgent need to have a closely international collaboration, just like us. So between Harvard and Guangzhou in tracing to the sources, targeting treatment, and vaccine in particular. So, okay, so I would like to express my thanks to all of these colleagues to provide me very useful message of that. Thank you very much.
Wonderful. Dr. Zhong, thank you very much. Let's move to Salim Abdool Karim. Please share your screen and show your slides. Thank you.
Thank you very much, Dr. Daley. It's a great pleasure and an honor to be with you here this morning. Thank you very much for inviting me. I just want to check that you can see my screen, COVID-19 in Africa. Can you see my screen?
Yes.
Yeah, we're all good. Thanks.
Yes.
So let me just quickly give you a sort of snapshot of the epidemic in Africa. At this point, we have documented close on to 1.5 million reported cases throughout Africa, with about close to 36,000 deaths. It's a case fatality rate of around 2.4%. And you can see we have over Africa, if you take all of the countries together, have now just passed the peak and are on the decline. Much of that is driven by the epidemic in South Africa, which accounts for between 40 and 45% of all cases at the moment. The deaths, as you can see, are shifted slightly, running about 2 weeks behind the actual number of cases. And if we look at the continent overall, the top 5 countries, South Africa, Morocco, Egypt, Ethiopia, and Nigeria, just these 5 countries account for 2/3 of all cases. We do have some challenges in that reporting is not occurring in some countries, and in others, there is some degree of under-testing. And I'll deal with that briefly now. So why is it that COVID-19 seems to be less severe than expected in Africa? Well, we don't have definitive evidence, but certainly it seems like some of the following factors may apply. The first is underreporting and under-testing, which I've touched on. And it seems they may play a role, but we are not seeing long hospital queues with patients with respiratory distress. At the African Task Force, we get detailed information from countries across the continent. So even if there is a level of underreporting and under-testing, there isn't a major hidden epidemic that's expressing itself in hospital queues at this stage. And it seems that one of the important factors is Africa's youth dividend, this younger population. And if one looks at sub-Saharan Africa and looks at the population pyramid, one sees the dominance of younger individuals. Compare that to the US, where you can see it's a much more even distribution across the different age groups. So Africa's youth dividends, the fact that a large number of those becoming infected are younger, where the death rates are lower and the severity of the disease is less, plays a role. It's also thought there was less initial seeding because of less initial travel, and many countries in Africa went on very early lockdowns. In fact, much of Southern Africa went on lockdown very early in March, and there's been very strong and consistent political commitment to fighting COVID-19 at the African Union. So even before the World Health Organization recommended masks, most of the countries in sub-Saharan Africa had already adopted mask wearing. But it's not just been about the epidemic, it's also about the way in which the response was coordinated. The task fell to the Africa CDC, a new organization relative to others. It's just about in its 4th year. But it very quickly, early on, established a task force to coordinate activities across the province. And importantly, it set up a platform to coordinate purchasing so that individual countries with their small purchase orders who would ordinarily struggle, that the combined purchasing power that the entire continent brought enabled us to buy equipment like PPE, like testing. All of that was bought in bulk and then distributed, enabling us to have a much more coordinated response. And we're not competing against each other for the limited access to, for example, test kits. So let's look at just one of the countries, the country that has about half of all the cases, just below half of all the cases in the continent, and that's South Africa. With the first case occurring on the 5th of March, in the first 3 weeks, it looked like the epidemic was growing very much on target, along almost at the same rate as the epidemic in the UK. The doubling time in those first 3 weeks was a doubling of every 2 days. However, within about 10 days of the first case, South Africa declared a state of disaster. And that meant closing the schools, banning international travels, prohibiting gatherings, and about a week later, a national lockdown. And that led to an immediate slowing of the epidemic. So within about 10 days of declaring the state of disaster, the doubling time went from 2 days to 15 days, literally flattening the curve. And with that flattening came much of the hardship that we saw that occurred under the severe lockdown of level 5 and level 4. But we knew that the lockdown was really not sustainable for any length of time. So as the lockdown was eased into what is best described as lockdown light under level 3, the epidemic started growing again. And we reached our peak and have steadily declined and have reached a stage now where we have a pretty low level of endemicity. At the same time, you can see how admissions rose in the gray bars and how our deaths started to increase with a bit of about 2 to 3 week lag time in the red line at the bottom. So we are now at that stage in the epidemic where we are post the first wave, and we are now busy preparing for the eventuality of a potential second surge, which we don't yet know when it will occur, but think it may occur in December. So why is it we had as few deaths as South Africa has about 17,000 reported deaths, and with excess mortality taken into consideration, you can double that if you need, if most of those deaths were also COVID related. I thought that among the things was the fact that our early action meant that we did not face our initial surge and our peak in April. If it occurred in April, we would have had lots of deaths because we were just simply not prepared. However, pushing the epidemic back by about 2 months enabled us to prepare. The picture on the right is the Cape Town International Convention Center. In a matter of just over 5 weeks, the convention center was converted into an 800-bed hospital with oxygen supply at every bed and a 200-bed ICU. So the nature of the preparation ensured that no patient who needed medical care went without a bed. One of our big problems was going to be oxygen supply. I mean, I don't know if you've seen the headlines last week, India ran out of oxygen. And running out of oxygen in this situation is deadly. So we knew right at the beginning that we were not going to have enough oxygen for the peak. And so arrangements were made with the 4 big suppliers to redirect commercial and industrial oxygen to medical purposes so that we would not run out of oxygen. And throughout the peak, when we were under maximum pressure of over 14,000 cases per day, never ran out of oxygen. Also, the use of, we were less keen to proceed immediately to mechanical ventilation. We had watched the experiences of our colleagues in the US, in Italy, in China, and we're now using less invasive methods, such as high-flow nasal cannula. By then, we also had the results of the recovery trial with dexamethasone. Our younger population probably also contributes. There are many other possible explanations, but these would be speculative at this stage. One of the impacts that we had to deal with was the impact on the economy. The World Bank estimates that we are going to witness huge losses in terms of output, and that COVID-19 is going to set off the first recession in Africa in 25 years, with growth forecast in the negative for this year. So the impact and the cost of this epidemic has been enormous. But what was key in what we were trying to do was we knew that if we simply went with our traditional public health model, where we would understand the modes of transmission, develop our prevention programs, we would pilot test them, we would adjust them, try to get early adopters to then influence, and we would then get diffusion. And by the time we did all of that, the epidemic would have overrun us. So we knew we had to act quickly. And so the actions that were taken, you think about, within the 10 days of the first case, at a point at which we had about 400 cases and not a single death, we had to take drastic action. And so the whole idea being that initially we would use institutional authority to get people to reduce their risk. In other words, through stay-at-home orders, through reducing things like mass gatherings. And so what we had initially was government action. But we knew we had to pivot away from government action to ensuring that people could then take agency. Once they understood this disease, once they understood what was going on, they would move from a situation where they needed government action to one where they could take action, to get self-efficacy, where they could then control their own risk through wearing a mask, through social distancing, through hand hygiene. And so this shift, this pivoting the prevention paradigm from government action to individual action has been key. It's been a challenge, but it's been key to how we have controlled the spread of the virus. And now we are moving from self-efficacy to an approach of looking at it from a collectivism point of view. That if you don't follow the rules, it's not just that you put yourself at risk. You put everybody at risk. You put your colleagues at work, you put your family, you put your neighbors, you put people in your public transport. And so this whole approach of pivoting next from the individual behavior to behavior for collective good. And that fits in well with the paradigm and the social norm that President Mandela instilled in much of our country, which is the concept of Ubuntu. Ubuntu is where you take your social context into account, where I am because you are. And so we use that concept to talk about I am safe because you are safe. You are safe because I am safe. Our collective interdependence is the basis on which we'll protect ourselves going forward. And so when we look at how we are responding in much of Africa, we have shifted gears from not looking at the response as a sprint as we did in March, but now looking at it as a marathon. We've moved from the epidemic situation where the virus was spreading, we were trying to flatten the curve to a point where we eventually got to a level of low transmission. And now we're trying to keep this by coexisting with the virus until a vaccine or a cure is available. And we recognize that we're going to have to deal with this for a long time. This is not something that's going to just go away. And that low transmission is essential, not just for good health, but also for economic recovery. And so this whole effort to transition from anxiety to self-efficacy and to empower people to act in the interests of the community and our interdependence with prevention to mitigate resurgence is our whole strategy. And we're doing all of this while ensuring that we are better prepared for the second wave. And to do that, we're building the public health surveillance. We have detailed monitoring systems in place. And as we're putting the public health response in order to prepare for future outbreaks and waves as they may come. And we've come to realize that dealing with this epidemic is just the start. As it's been a baptism of fire, but we've seen several other epidemics in Africa, Ebola, other viruses, and there will be many more to come. So we have to build sustainable institutions if we are to deal with the threat of this virus and many more to come in the future. Thank you very much.
Thank you, Salim. Let's turn it over to Fabio.
You see my slides?
Yes.
Fine. So hello to everybody. I'm Fabio Ciceri. I am from Milan, from the Raffaele Scientific Institute. We are a big institute, 1,000 beds, a university. I am hematologist and I lead bone marrow transplant activity. And I joined the COVID efforts during last spring as a coordination for scientific direction and clinical research in our institute. So we'll go through the epidemics in Italy. We were let's say the first country in Europe touched by the wave in late February, March, and April. As you can see from here, the cumulative patients were actually wave in April and March, and then we had a quite stabilization. Now we have a new cases, but what I would like to share with you from now is that actually the number of deaths, the cumulative number of deaths are still the same. So in the last wave, we actually have a very, very few deaths. I would like to underline here that the lockdown in northern Italy was very fast at the beginning of the pandemic. And I think that this translated to some important consequences in this scenario. So this is actually the curve of new patient daily in our region, which was the most affected region. Different colors are different, actually different towns. And Milan was the most important with Bergamo, Brescia, and Piacenza. Again, as you can see, lockdown was quite fast in the few days after the wave. And we think that this translates into the fact of actually a rapid, fast control of this pandemic in our region. The effect actually was not only due to lockdown. We had a fast reshaping of our hospital. In few days, the largest hospital of the region actually was completely dedicated to COVID-19 patients. Most of the beds in medical area of the wards and even surgery were completely dedicated to COVID. And essentially only hematology, bone marrow transplant, and reorganization through the region in centers dedicated to some elective treatments, such as vascular surgery, neurosurgery, oncology, and some important activity like hematology, stem cell transplant, were actually focused in those centers. So essentially, the COVID-19 shared some 80 to 90% of all the national healthcare assistance. I have to say that this is perhaps the results of one national healthcare system that actually have a good governance or activity. That is that all was coordinated at the regional level and at the national level. In other regions, they actually accepted or locked down and other recommendations that came from the most affected area in the north. So I think that this is a model that translated into a good control. Just looking at some selected centers, I have to say that our national assistance, healthcare assistance, actually translated into some important research activities. Essentially, this was the model in our institution and many others. We actually collected information and biobanked materials from patients since the early beginnings and very systematically. And that's like, actually that organization led us to enroll patients into clinical trials in a good proportion with new drugs, some selected new drugs. And now we're running some biological studies thanks to the availability of those clinical and material informations. So one important observation in the first 3 months was the fact that the mortality rates dropped significantly in time. And this was actually the sum, we believe, of an earliest intervention in patient and the introduction of some important treatments systematically thanks to the observation that came from this experience. So we dropped from 25% mortality to 2% mortality. And now if we see at the last months with the few numbers we are less than 1% mortality among patients admitted, which is of course the lowest rate we observe. And again, if we see the proportion of new cases as compared to numbers of patients admitted in the hospital, you see that actually thanks to a good control of the early manifestation, clinical manifestation at the territory level by general practitioners, I think that we can actually admit only a small proportion of patients as compared to the total number of new cases registered in Italy. Finally, would like to mention that the message that the way we see forward with this, let's say, third phase is that now we have an early testing and tracing of new positive cases, which is largely available in the population. Of course, we can have a networking between the territory and the hospitals to allow an early intervention in patients with symptomatic disease. And those patients that need an hospitalization, they are referred to some, let's say, hubs or central, some very few centers, we are one of them, to manage COVID-19 patients. And in these centers, we have clinical trial with new agents available at the investigational trials. And again, we have built up in these centers clinics to follow the patients cured that show actually some post-COVID chronic manifestation. These late effects are actually under the observation and under the management of a multidisciplinary teams. And that would be very helpful to minimize the impact of this chronic, let's say, sequelae. So at the end, I would like, of course, to thank many doctors and professional nurses. Hopefully in our hospital, no one professional was really died, but many were affected during the COVID period. And despite this, some selected areas like bone marrow transplant were all the time COVID-free in 6 months. And this is, of course, we're very proud of this. And this actually is the sign of the sum of all the containments and all the measures applied in this series. So thank you for your attention. And of course, I would like to accept any question from your side.
Thank you, Dr. Ciceri. And for a final summation of the lessons learned, we'll turn it over to Dr. Paul Farmer, the chair of our Department of Global Health and Social Medicine.
Thanks very much, George. I'm going to speed this up as I know we're behind the time, and also because a number of these issues have been addressed by Megan and others. If I could have the next slide. I mentioned scientific error in a generic way here, and that would include the misinterpretation of available data, which, as we've heard in each of the presentations, we're always at risk for it, and it can have negative impacts. As has already been mentioned by a couple of people, including George in his introductory remarks, we need to look at pathogens, of course, which have different modes of transmission. And as Megan mentioned, many of the ones that afflict humans do have zoonotic roots, and many are viruses. We also need to understand pathogenic forces. Overcrowded hospitals with nosocomial transmission, meatpacking plants, at least in this country and I believe elsewhere. And this last image, just as a reminder from an Ebola treatment unit,
that there are Ebola treatment units where there is no treatment really to speak of. They're really just isolation units. And therefore you might expect, if they worked to isolate without providing good clinical care, that there would be high case fatality rates. And that occurred in West Africa in this epidemic. But what's more, they also don't work because, as has been pointed out, when people are sick, they seek care. And when they're in the clinical desert, if I can use the metaphor, that care is very often provided not by health professionals who are in rare number, but by family members and traditional healers. A little bit more on that if we have time in discussion. Next slide. Now, just a word about what we're called the filoviruses for their string-like appearance. I want to introduce two terms, and I can be satisfied with that, George, as the take-home message: clinical nihilism and containment nihilism. And it's rooted in the origins of these two viruses, Marburg and Ebola. Marburg is an interesting story. It was really first identified when monkeys, not for research purposes, but for vaccine production, were transported from Uganda, I believe, through London and into the German cities of Marburg, Hamburg, and then on to Belgrade in what was then Yugoslavia. They caused in the laboratory a series of outbreaks, which were then transmitted to the professional caregivers and family members who cared for those patients. And so a new virus, thanks to electron microscopy and other tools not available then and rarely available now in Africa, this new virus was named. And a few years later, in a mission hospital in northeast Congo, in a place called Yambuku, in what was then Zaire, there was an explosive outbreak, and it occurred in a mission hospital. But I want to mention mission hospital with quotation marks because the hospital did not have a single attending physician. So like the Ebola treatment unit, where the ETU is short on the T, or the community care center, where it's short on the middle C, care, you still have situations where healthcare professionals are too few in number and lack the staff, space, and systems required to move forward. Next slide. So what does clinical nihilism look like? Well, first of all, if you notice, and case fatality rates or mortality rates, as Professor Ciceri just said, are critical to understand what is going on in a certain time and place. With Marburg, even though this was an unidentified pathogen, close to 80% of those affected survived. Meanwhile, when Marburg was later seen in its natural habitats, which were usually rural and disrupted areas in Central and Southern Africa, mortality rate routinely hit 90%, and the average was well over 80. It was the same thing during the recent epidemic that Megan described of Ebola, where at the beginning of the epidemic, when less was known about the pathogen, in fact, it took months to identify Ebola as the causative pathogen, the culprit, mortality was at 70%, and it really wasn't much different at the end of the epidemic. Meanwhile, patients who were transported, Ebola patients who were transported out of the clinical desert into the United States or Europe did well, with no Americans perishing, a small number, fortunately. Next slide. Now, what does clinical nihilism look like? And we have to watch out for this. Anybody who has worked, as many of those on this call have, and many listening in, know that there's always a gap between the development of a new therapeutic, whether it be an antiviral, monoclonal, or polyclonal antibodies, whatever, and its widespread distribution. It's the same with vaccines, and that is what we're facing now, as Professor Zhong reminds us. So when you see claims and they often come from public health authorities and development economists rather than clinicians, claim that the treatment of a pathology in a pandemic, a worldwide distribution or broad distribution, when it's impossible, unfeasible, not cost effective, not sustainable, make sure and pay attention that you're not seeing clinical nihilism. And it's the same thing if you look at leukemia in children in a rural area of Africa, et cetera, et cetera. This is something we're very accustomed to. With the filoviruses, it was extremely marked in West Africa. That is, for those transported out of the clinical desert to the United States or Europe, there were no calls to cut back on ICU care, on dialysis with renal failure, on mechanical ventilation with respiratory failure, but that was routinely the case across West Africa and throughout the epidemic. And if we have time, we'll go back to this. Next slide. But what I want to close with is something, and there were significant errors about how Ebola spread. For example, just because a pathogen is introduced from a zoonotic source does not mean that contact with animals is at all important in the ongoing propagation of the epidemic. And so calls to stop eating bat soup or to avoid bushmeat were not going to slow the epidemic of Ebola in West Africa. It had already been unleashed and was spread from person to person through the lack of infection control, which means a lack of PPE or lack of training, etc. Next slide, please, and to close up. I was going to talk a little bit about how this occurred among non-healthcare professionals, like some patients of mine, but I think I'll forego this. Next slide. I want to turn in closing to something that I think we're seeing in the United States of America. George mentioned in his introductory comments that we've had substantial failure in disease control and containment of COVID in the United States. And this is well known, I'm sure, to our colleagues across the world. However, containment nihilism is different from clinical nihilism. Clinical nihilism says, look, it's all about containment. There's not much effort in trying to save patients' lives. The real focus is on containment. And this is a very common logic in public health. But containment nihilism is what we're confronting right now in the United States. In Massachusetts, the governor was complaining in quite much more colorful terms to us that people had already given up on contact tracing, and this was in April. And you see it right now as COVID hits the White House, no contact tracing. And the New York Times is doing contact tracing, and I'm sure some of it is being done within Washington, but the CDC is not involved, as far as we can tell, in the contact tracing that's required to understand the current epidemic. Mayors across the country have proclaimed it's too late, and this is a real challenge right now, since experience from China, as Dr. Zhong has reminded us, but elsewhere in East Asia and in some parts of West Africa have shown us that contact tracing should play a role. In my last slide, I would just mention we were lucky enough to be contracted by the state of Massachusetts. And the we here involves Partners in Health and NGO, but a number of HMS faculty, students and trainees have worked for or volunteered for this effort, which recruited in the course of a couple weeks in April over 1,200 contact tracers. And we'd like to believe that that's one of the reasons that we do have less community-based transmission in Massachusetts. And of course, many parts of the university, including those here today, have collaborated on this effort. So let me close there, and I'm sorry I didn't get through everything, but I look forward to the discussion, and thank you to my colleagues.
Thank you, Paul. So we have 15 minutes left for questions. There are already a number appearing in the Q&A box. Please post your questions and we'll try to answer as many as possible. There have been a couple of questions put forth about the challenges of managing respiratory illnesses when they overlap. We're in the United States heading into the fall and winter season, and we anticipate a rise in flu infections. So I would ask Dr. Zhong, as a pulmonary specialist, how do you imagine confronting the overlap of the seasonal flu with COVID?
Yes, thank you. So I think, so during this outbreak of COVID-19, I think some of the retrospective study showing that although it's not a season for the outbreak of influenza, but it actually had some percentage, so very few percentage, so like some paper were 0.4% to 2% of the co-infection of COVID-19 and influenza. So, but of course, it's not the outbreak of COVID-19. So during this this autumn to winter, I think during the it's going to the peak to the influenza outbreak. I suppose we'll be getting much more of this co-overlap infection. And we have no idea, so how serious of the disease of the co-infection of that, but actually exist. So based on the PCR test, not the specific IgM test. If it based on the IgM test, it would be somewhere in Wuhan, that would be close to 40%. I don't believe that. As probably the using PCR test would be much correct for that. But anyway, from the coming winter, autumn and winter, that will be a big problem. And also people will be asking if it is a co-infect with two diseases, or it is first with the COVID-19 and second influenza, or vice versa, first influenza and second COVID-19. What happens of the outcome? How serious of the disease of it will be? That should be under investigation. So anyway, I think that will be a big problem of that.
Oh, that's going to be fascinating to watch. Dr. Karim, given that we've come through the winter in the Southern Hemisphere, have you any lessons learned? Was there experience with flu overlapping with COVID in South Africa?
Yes, thanks for that question. We monitor flu through a sentinel surveillance program at various healthcare facilities and in communities. And we do this every year. And normally, by about June, we start seeing quite a few positives. We were struck. We saw, I think, a total of about 8 positives for flu in the entire winter season. So whatever we've been doing for COVID-19, it's had a dramatic impact on influenza. We have seen so few cases, and we think partly it's about the social distancing, but mostly we think it's about mask wearing playing a role. And so we've basically avoided this year's flu epidemic. It's also interesting, we seem to have skipped the usual spread of RSV in children, which is an important cause of death in children. And we skipped that as well. So there's been, we're only beginning to understand that the interventions we've put in place are having a whole lot of spillover effects, both negative and positive.
Thank you. There's a very interesting question from Dr. Stephen Kahn, one of our alums and a member of our Global Health Advisory Council, to Dr. Murray. And I hope, Megan, you will take a few minutes to talk about the BCG vaccine, which has already been widely distributed across the globe, and the information that we've learned about the impact on respiratory illnesses in general and COVID in specific.
Yeah, so we're working on trying to setting up a clinical trial of BCG to see whether it's going to have an impact on COVID disease and death. This is not a novel idea. There's about, I think, 18 clinical trials going on currently. Most of them are in healthcare workers. So it must seem, a bit odd if you aren't a BCG person why would a TB vaccine have an impact on a virus? But it turns out that we've never really understood exactly how BCG works. BCG is an attenuated form of M. bovis, which is a very similar infection to MTB. And it's been used since 1920 in children to prevent childhood TB. But it's also been shown in those kids to prevent early death, which probably was not explained by its reduction in tuberculosis. So over the decades, a theory has emerged that BCG is doing something other than simply providing protection from TB, that it is having an impact on innate immunity. And it increasingly looks like that's mediated through epigenetic modification of innate immune cells, so macrophages and natural killer cells. And there's been really a lot of laboratory-based work and animal work that shows that that's true. Most recently, a trial of BCG to prevent viral respiratory infection in the elderly in Greece was published, actually last month, that showed an 80% decline in respiratory infection in people who are probably being revaccinated, because this is Greece where BCG is widely used, in their adulthood. So we're very interested in whether BCG might protect also against COVID-19, and particularly in the most vulnerable groups. So in addition to all the healthcare worker studies that are going on, we're trying to target a group of people over 70 who are at the highest risk for disease and death.
Thank you, Megan. You've raised an interesting point that I think we've appreciated from the early data in Wuhan, and now is reflected in data across the globe, that older individuals and those with pre-existing conditions seem to be at the greatest risk for the severity of the disease. I could ask several panelists, what do we understand about the immunology of this disease that might explain why children are relatively resilient and protected, and what are the pathophysiologic mechanisms that explain severity in the elderly? Dr. Zhong, first, since you taught us this lesson very early from the data in Wuhan, and then we'll ask Dr. Sharp and Walker to weigh
in. I think that at the very beginning, I think in Wuhan, which is had quite a higher mortality as compared with similar, something like 5% of their death. I think that's not because of the disease per se, maybe because of the less of enough beds or medical care for those patients, and they have to live at home, and also the list of very basic medical care support, and then to cause some mental problems and so on. So that's caused a higher mortality of the disease. It's not because of the disease itself. And then after the so the support of the different part of the cities, so the mortality is going down. So because the majority of the patient, more than 80% or 85%, will be cured by themselves as a self-limited disease. And then I think in children, of course, so the disease, the severity is relatively mild. So we don't know actually the exact reason. Perhaps the immunofunctions not that mature, or some other not so respond so so strong in terms of creating the cytokine storm or something. But so nobody can make a clear explanation about that. So actually, so I think the higher mortality in Wuhan and the early stage, basically because of a lack of basic medical care, I suppose.
Thank you. Dr. Sharp, as the chair of our Department of Immunology, I might ask you to give your thoughts about what we understand about the immune response to this infection.
So we are at an early stage still of understanding the immune response to this virus. I think interesting work is that of Shiv Pillai, one of our MassCPR colleagues, who identified that the antibody response to the virus is suboptimal, which might explain why one sees low antibody responses, that instead of getting a long-lived antibody response, you get a rather short-lived B-cell response that's seen. And so I think that could be part of the issue. And so I think we have a lot more to learn about special populations, if you will, the elderly, the young, the obese. We know that the immune system is different at different stages of life. And I think, unfortunately, this virus is going to be a way for us to learn more about these responses.
Thank you. I'm going to return. I saw in the chat that Dr. Ciceri has some interesting data about the coincidence of influenza and COVID. I might ask Dr. Ciceri to comment, please. You're on mute, Fabio.
Thank you, George. We actually had the chance to look at the profile of antibody response to influenza, looking at especially IgM, so an early response in patients with the COVID-19 in acute phase of the peak of the wave, that is March and April. And at that time, we were on the queue of the flu epidemics in our region. And I can tell you that we found in severe forms of COVID, those patients requiring oxygen, we found around 50% of patients with IgM against influenza, as compared to only 2% in patients that were sent back from the emergency department because they were partially symptomatic. So there should be something related to the concomitant influenza to actually the severity of the disease, at least at that time in that population in our patients.
Thank you. I think the lesson to be learned is that it is still important to receive the flu vaccine to try to ward off the prospect of double infection, which could indeed be particularly severe. Thank you for that lesson. Dr. Karim, you spoke about Ubuntu, and one of the lessons that we've learned from the experience in China, in northern Italy, other parts, was that a very, very rapid and collective lockdown was perhaps the most effective way to ultimately control the peak and bring the virus under control. Do you have any recommendations for how we could spread the concept of Ubuntu here in the US or to other parts of the world?
That's a very good question. And when we look at just the underlying principles of community understanding, becomes fundamental to thinking about public health. Now, South Africa has a very long tradition, particularly in the Black communities in rural areas, of something called stokvels. Stokvels are where, for example, 12 families get together, and every month they will each contribute a fixed amount into a pool. And once a month, and when each month comes along, one of the 12 families gets the entire pool. So everyone knows that they have to make a short-term sacrifice, but they will get a reward somewhere along the way to make a major purchase of an appliance or something like that. So this collective trust that has to be built for stokvels, and stokvels are very widespread in the country. It's just an expression of the underlying philosophy. It's very difficult to do that in societies that promote individualism. It's almost impossible to build, and we have that in several of our own communities in South Africa. So I don't have a solution, but I can tell you that it's built on other components of the way society works. It's not in isolation for COVID.
Yes. Well, but what you're emphasizing is the importance of learning from the experiences in other communities and adopting the best practice, which does happen to be widespread collective action through mask wearing and social distancing. We just have one last question. There's a number of points brought forth about the vaccine, the prospects for having a vaccine, what timing we might expect, and how one might imagine fairly allocating the vaccine. And for that last comment, I'd like to ask Dr. Bruce Walker, who is the director of the Reagan Institute of Mass General, Harvard, and MIT, and also the co-lead of the Massachusetts Consortium on Pathogen Readiness. Bruce, I'm going to give you the last word. And you're on mute.
Sorry, thanks very much, George, and thanks to all the speakers. One point I'd like to make relates to what Arlene was talking about the infection itself causing damage to the immune system. I think we can be optimistic that vaccine-induced immunity will be different and probably more long-lived because the virus is not there damaging the immune system while the immune system is trying to respond. I think that of the vaccines that are in development, I think there's a high likelihood that they will work. I am hopeful that multiple vaccines will make it to the finish line because there's such an enormous need globally. If we can have a vaccine that's a single dose, that means that we need 7 billion doses instead of 14 billion doses. The FDA, I think today has really acknowledged that they will make sure that testing is completed, that there's a longer follow-up. So I think we can be optimistic about this. It'll take a while before, into next year before it's widely available.
Thank you. I want to apologize, that's all the time we have. We couldn't get to all of the questions, but I want to thank our presenters. I want to give a tremendous sense of appreciation from the United States to our colleagues in China, Dr. Zhong, our colleagues in Italy and Europe, Dr. Ciceri, our colleagues in Africa, Dr. Karim. And thank you very much, Drs. Murray and Farmer, for those excellent summaries. And thanks to our audience, whether you're a member of the public or a member of the news media, your participation in this conversation is more important now than ever. I wish you all well and stay safe. Thank you very much.